Afternoon, everyone. I'm Dr. Prableen from the organizing team of BMCHRC IPCON 22. So we come to the last lap of this knowledge enriching conference. And for this session, we are going to deal with the topic managing patients with difficult pain. Our theme leader is Dr. Gaurav Sharma, sir. He's Associate Professor, Department of Palliative Medicine, SMS Medical College and Hospital, Jaipur. He's presently the Honorary Treasurer of ISSP and Honorary General Secretary, ISSP Jaipur City Branch. He was bestowed with the Pain Ambassador of the Year Award in 2019. Sir, over to you to introduce our chairs.
Thank you, Prableen. So the topic of our session is managing the patients with difficult pain. So we all know the normal patients we can cover with the WHO ladders, mild, moderate, severe, and according to the pathophysiological classification, nociceptive and neuropathic pain. But these are the clinical scenarios which we have to be dealt with the special consideration and with special knowledge. So to chair this special knowledgeable session, we have two distinguished, experienced palliative care physicians. Our senior respected sir, Dr. P.N. Jain sir, who is presently professor at Tata Memorial Hospital in Department of Palliative Medicine. He has a lot of publications in peer-reviewed journals, and we all know him. He doesn't need many introductions. So without wasting the time, I would like to invite P.N. Jain sir to start the proceedings. Thank you, sir.
We are listening the echo also. You are also listening the echo. You are listening the echo.
Sir, at our point it is not there. That it might be due to two mic or two gadgets simultaneously opened. Is that so at your end? Mobile and laptop both are running simultaneously?
No, we are not. Acha.
We are clear at your our end, sir.
Okay. So without no, I am not opened in mobile. And thank you, organizers of. Okay. Only one device. Very good afternoon, and thanks organizers of IAPC for giving me this opportunity, honored opportunity. This is the session with difficult pain. So many patients are having not any relief with all the whatever oral analgesics are given, and there is problem with the diagnosis. There may be problem with finding the right analgesic with them, finding the right psychosocial approach, and so many and so forth, because it's a total pain. So physical, psychological, social, financial, spiritual, all the aspects have to be assessed for tackling the pain. Only analgesics do not actually alleviate the pain. It is only 30%. That you will find that only oral analgesics are working. So we are having very distinguished 4 speakers in this session to deal with this or crack the solution for this difficult pain scenarios. So first speaker is Dr. Babita Ghai, who will speak live, and other 3 speakers are having recorded videos. So first speaker is Dr. Babita Ghai, is a professor of anesthesia and heading the pain management group in PGI Chandigarh. He has got many publications, more than 100 publications. She is a fellow of the National Academy of Medical Science. She has been for last 10 years in the executive body of the Indian Society of the Study of Pain. She is speaking today on refractory neuropathic cancer pain, challenges and management. Followed by that, there would be two international speakers, difficult to manage breakthrough pain by Dr. Andrew Davis. And then there would be a speech by the psychosocial pain, going beyond nerves and analgesic by David Olivier. And finally, again, our own, one of the great pain physician and palliative care physician, is associate professor now in Alenia Institute in Batenda. He is associate professor, so young dynamic pain physician, and he will talk about interventions to difficult such cancer pain. So about the other two speakers, I will talk about the other two speakers. They are also very distinguished one, and they are, one is from London, and another from Dublin. So we will start with the session. Dr. David Olivier is the, please give me the slide, show me the slide, please. Yes, Dr. David Olivier and Dr. Yes, other slide, please. Show me the slide, please. Yeah.
डॉक्टर एंड्रयू का दिखा दो.
And Dr. Andrew का दिखा दीजिए. Dr. Professor Andrew Davies is Professor of Palliative Medicine in Trinity College of Dublin. He has got 20 years experience in supportive and palliative medicine, and he is president of MASSC. Dr. David Olivier is a consultant in psychosocial palliative care, social worker and counselor and educationist. He is a visiting professor of Middlesex University, London. He has got very large experience, 36 years in palliative care, very creditable. And he is working with the families in cancer, palliative care, culture and ethnicity, loss, grief and bereavement, staff stress, self-care, clinical supervision, couple counseling. And finally, his interest is rediscovering my Indian roots through the palliative care. So he must be working in India some time back. So they are this is going to be very interesting talks. So let us start with Dr. Babita Ghai with the neuropathic pain, finding the challenges and management. Welcome, Dr. Babita Ghai, please.
Thank you, sir. Thank you for your kind words. I shall be just sharing my screen as I'm presenting live. So I would just like to ask that, can you see my screen?
Yes.
Yes. And is it on the slideshow now?
Yes.
Thank you, sir. So thank you for your kind words, sir. And as we are dealing with the challenging situations here, the 4 difficult pain scenarios. I'm sorry. Okay. In fact, my challenging talk is to cover this challenging refractory neuropathic cancer pain in somewhere around 18 to 19 minutes. So I would start without wasting any time. Currently it's 2:08, so I would like to finish it by 2:27 or 2:26. I shall be speaking on refractory neuropathic cancer pain, the challenges and management. I don't have any disclosures or conflicts of interest. So what shall I be discussing over this next 18 to 19 minutes? Exactly what is refractory neuropathic cancer pain, that is NCP. What is its bit of about its epidemiology, the etiology, some of the risk factors, challenges being faced in NCP management, refractory NCP management, for its definition with regards to its pathophysiology, assessment, management. And finally, I will talk about the management, which is actually an interdisciplinary multimodal and management, as greatly highlighted by Dr. Jain. So what exactly is the etiology of neuropathic cancer pain? That is being attributed to nerve damage because of cancer per se, because of its mass effect or damage to the nerves, or it is because of the treatment included including chemotherapy, radiotherapy, or surgery. So there might be a direct nerve invasion or nerve compression by cancer per se, as I said, because of the mass effect, or there can be neural toxicity because of chemotherapy or radiotherapy. The prevalence of neuropathic cancer pain is reported to be as high as 40%, and there has been various categories it has been divided into, that is plexopathy, radiculopathy, or peripheral neuropathy. There are few of the risk factors which are being identified, that is young age neuropathic pain at the onset of cancer, incidental pain which has been diagnosed or been taken during the assessment of the cancer pain assessment, psychological distress, previous opioid use, high tolerance, a history of addiction, and impaired cognition. These are the factors which has been proposed to have high risk for developing refractory NCP. So as we say that we are dealing with refractory NCP, there are definitely huge challenges being posed with regard to its definition, pathophysiology, assessment, and management, and I shall be dealing with them one by one. So what is challenge one? That is, what exactly is refractory neuropathic pain? There has been no clear-cut definition of refractory neuropathic pain. Whatever the definition is taken from the non-cancer neuropathic pain and is applied to the cancer neuropathic pain. So what is refractory neuropathic pain? It is the pain which is not responding to the treatment. It is persistent. There have been many misnomers or very many terms being used: persistent, refractory, pharmacoresistant. So what to be used? We have been usually using a term which is refractory neuropathic pain. So what exactly is the definition of neuropathic pain, refractory neuropathic pain? It was proposed by Smith et al. And it was used for the non-cancer refractory pain. That is, according to the international consensus on component of refractory neuropathic pain, the definition is a minimum duration of 1 year, which obviously cannot be applicable to the non-cancer, into the cancer neuropathic pain. So that is why I have highlighted it with the strike through that this definition is taken from the non-cancer scenario. There have been when the 4 trials of the drug of the known effectiveness is failed, adequate duration of these trials has been tried. That is, a clinician has tried approximately 3 months with maximum tolerated doses, and outcome of the treatment is still not as good as which a clinician would expect, and the pain severity and the quality of life is affected. Then we call it as a refractory neuropathic pain, and this definition is extrapolated to the cancer pain scenario as well. Coming to the challenge number 2, that is, though we know the etiology, but pathophysiological mechanism of neuropathic pain are just postulated and hypothesized. There has never been a proven exactly proven pathophysiological mechanism, and we propose multiple pathophysiological mechanism. And what are they? These are chemical excitation of nociceptors, central sensitization, wind-up, excitotoxicity, sodium channel effect, ectopic discharge. So think of so many pathophysiological mechanisms. So what are we going to do? We are going to aim at various pathophysiological with the postulation that the drugs or the management modality would work. So we also know that more than one mechanism of action is likely to be involved in clinical practice, and hence a multimodal interdisciplinary pain management is the aim for the management of refractory neuropathic cancer pain. I would say in the challenging situation, there is still a silver line which is seen in the dark. That is, if we are able to find multiple pathophysiological mechanisms which we are postulating and finally being able to prove either in the experimental model or in the animal model, then we would be able to find at least multiple mechanisms which may help us target the therapy in future, and hence we can determine the newer experimental drugs or the modalities. Moving on to the challenge number 3, that is the assessment. Assessment of refractory neuropathic or the neuropathic pain. Neuropathic cancer pain is itself very difficult. Because the assessment is difficult, obviously the management is going to be very much difficult. So there is no gold standard which is seen in the literature for the neuropathic pain assessment. These are very much postulated screening tools which we have heard since morning, that is DN4, PDQ. However, their sensitivity and specificity is different. Hence, to reach to the absolute diagnosis of neuropathic pain itself is challenging. And usually we do not say neuropathic pain alone. We say it with the component of nociceptive pain as well. Hence, we have to manage both the components. Moving on to the fourth challenge, that is the management itself is challenging. It is tedious, it is complex, it is difficult. The recovery requires several months, maybe years before a complete recovery can be achieved after an injury to the nerve. Hence, moving on to, after going through those challenges in sequence, let's move on to the management aspect of refractory neuropathic pain. The goals of neuropathic pain management, cancer pain management, NCP management is mainly the quality of life improvement. What do we do the contemporary in this non-cancer pain management? We usually say the functional improvement, and the functional improvement is the goal in non-cancer neuropathic pain. However, this goal is changed in cancer neuropathic pain. It is the quality of life improvement of the patient, which is the major goal. And what are the other goals? Improvement in definitely the pain threshold, so that the patient is able to feel pain less. Improvement in physical activity, if we can achieve. Reduction in the narcotic doses. Reduction in the healthcare consumption, definitely a main aim. And if the patient is able to still participate in the recreational activity, and if possible, a cancer patient is able to return to the work, then that might be another goal. What are the principles of management of refractory neuropathic NCP or neuropathic cancer pain? The single most important ingredient of any management of the chronic pain, more so of the chronic more chronic cancer pain, is existence of a healthcare providers who are willing to work together as a team. So hence, a teamwork is required. We should be aiming at a holistic biopsychosocial spiritual modality of pain management. Hence, commitment of these providers to the patient, and patient must be motivated. These are the principles for management of this challenging situation. A collaborative effort of the group providers, including the physicians, nurses, psychologists, physical therapists, vocational counselors, social worker, support staff, is essential. And basically, an interdisciplinary pain management is the final interdisciplinary management, multimodal management is the final theme for the management of these patients. Extensive interaction between the team workers should be there, so that they reach to a common agreeable goal for the management of refractory NCP. Management includes non-pharmacological, pharmacological, minimally invasive interventions, advanced interventions such as neuromodulation or intrathecal drug delivery, and in few cases, surgical intervention, which I have missed out, is there is still a role of radioablative procedures, which can be considered under surgical intervention. There should be a continuum of pain treatment management that should be started from the least invasive to the most invasive. And whenever it is required, it can be co-adjunctly applied. First part is the psychosocial counseling of the patient is extremely important. Hence, the patient should be communicated. That is extremely important. There should patient education about its disease and its management, body mechanisms, various exercises, roles, psychological counseling should be started right from the beginning. That would definitely alleviate or take care of at least 20 to 30% of the problem of the holistic management of the patient. And the patient should be always explained or counseled about that. Even if the disease is not curable, it might be manageable, and we will be reaching to the realistic goals with the expectations of improving the quality of life and minimizing the pain as much as possible. The pharmacological managements include, before I say about the management part, a word, I would say that unfortunately, no agent prevents the NCP, more so about the refractory NCP. Hence, the current treatment modalities focus on the reducing or alleviating the symptoms. American Society of Clinical Oncology guidelines suggest that the first drug of choice for drug of choice for NCP, that is neuropathic cancer pain, is SNRIs and SNRIs, including venlafaxine and duloxetine, gabapentin and pregabalin, TCAs, which is not useful according to this guideline is the drugs mentioned, and few of the drugs which are not recommended are mexiletine and levetiracetam. Other agents which can be used for refractory neuropathic cancer pain. Over here, I would like to just mention that when Gaurav gave me this topic, his thought process was that I should be talking about opioid-resistant refractory neuropathic cancer pain. Hence, I am not highlighting on the opioid aspect, which is the integral part of neuropathic pain management for the cancer patient. So if the patient is still resistant to the opioid and the patient still have NCP, then opioid manipulation is another aspect which we can look into and try. Parenteral delivery to oral delivery to the parenteral delivery, rectal delivery, rotation, combination, methadone, buprenorphine agonist and antagonist uses. Non-opioids and co-analgesics can also be used, which include topical 5% lignocaine patches, capsaicin patches 8%, or low percentage of capsaicin patches, NMDA receptors antagonists like ketamine, cannabinoids, and steroids. These are the threats. These are the modalities which can be utilized. And definitely, if the pharmacological intervention does not work, then we can move on to spinal cord stimulator, neuromodulation, or intrathecal drug delivery, more so for the intrathecal drug delivery system. So there has been a very beautifully comprehensive algorithm for management of neuropathic pain being provided by Bates et al., which gives this flow diagram, which all of us might be aware and would have gone through the various lectures of this conference, right? Starting from diagnosing the neuropathic pain, if there is an element of neuropathic pain or there is an element of nociceptive along with neuropathic, then going on to the first line management like TCA, SNRIs, gabapentinoids, topical, then moving on to the weak opioids, moving on to the stronger opioid, and then a specialist referral, moving on to the third line management of the drugs per se, moving on to the neuromodulation, low dose opioids, or the target drug delivery system. Before we just take message from these guidelines or these flow of guidelines, I would like to highlight some of the Indian perspective with the focus for this guide to these guidelines. What is that Indian perspective is that current therapy for the treatment of neuropathic pain is often unsatisfactory. Considerable variations are seen in the treatment pattern which exists in spite of availability of sufficient literature from various guidelines. And literature also reports instances of non-adherence to the treatment, to the guidelines and recommended doses used for the management of pain. Why this is so? So there is some gap between the guidelines recommendation and the real clinical practice. So what happens in Indian scenario, that I would like to give the message to all the delegates here, that whenever you are dealing with the pharmacotherapy, always start low and start slow. The recommended doses in the international guidelines are usually for the international weight, international anthropometric scenarios, not for Indian. So Indian guidelines are there, which are guidelines of Indian neuropathic pain, which recommends start low, go low. And in our clinical practice, I start amitriptyline as 5 milligram per day. Then we go slowly and increase if it is tolerated. Gabapentin to start with 100 milligram per day. Pregabalin to start with 50 milligram per day. And believe me, we have observed dizziness, giddiness, sedation, headache with these smaller doses as well, as high as in 40 to 50% of patients. This is our experience. Amitriptyline 5 milligram when you given into 80% patients. This is still unpublished. We are about to publish this. Dizziness was seen in 7%. This is with only 5 milligram dose. Early morning sedation in 11%, dry mouth in 4%, frontal whole headache was in 8%. And this is where highlighting again the aspect of low dose amitriptyline, pregabalin, gabapentin in Indian scenario. So why it is so? Why do we need so low doses to start with? Possibly because of the anthropometric differences, possible lower body size in Indian scenario. BSA is less as compared to the Western population. Moving on to the other drugs, we are well aware of TCAs, their side effects. I won't go in detail because of the lack of time. Anticonvulsants can also be used. Gabapentinoids can be used. SNRI, we should be well aware of their side effects, more so in cancer patient because they can cause constipation, they can cause dry mouth, and these are already been seen with the opioid in cancer patient. SSRIs also have their side effects. This is moving to the other analgesics patients who are not responding to first line management or to the opioids. Then lignocaine patches can be used, and there is a flow of the guidelines which is provided for the uses of lignocaine patches. However, we should be aware of minor side effects as well as the major side effects of the lignocaine patches before prescribing, and we should always explain it to the patients. Ketamine is another drug of choice, drug which has been very elaborately being used for refractory, and it has huge literature in cancer pain management. So there is one drug which has shown through the systematic reviews, through the meta-analysis, as well as through the RCT role in refractory NCP. However, I would like to highlight here that great variations are seen in the practice with respect to the use of ketamine for the type of pain being treated, the dose, the route, and the frequency of delivery. Corticosteroid is another drug which can be used for refractory NCP with its side effect kept in the mind, and it has been also frequently used in refractory NCPs. Cannabinoids, a word about them. According to the existing data, cannabinoids are safe and effective in control of different type of chronic pain, including the chronic refractory NCP. And nabiximol is an oromucosal spray containing 1:1 combination of tetrahydrocannabinoids, the principal psychoactive constituents of cannabis plants and the cannabinoid oil. However, I would like to mention here that my experience about the use of cannabinoids in the medical practice is negligible and is zero. There a word about an experimental drug. This is a marine fish toxin which is being used and been tried in the experimental model, that is tetrodotoxin, which has shown some promising effects. However, it may be the potential drug for the neuropathic and cancer pain relief in future. So as I say, it is the teamwork which is required for such challenging and difficult situation, that is to manage refractory neuropathic pain. If we don't go in hand, and if we do not agree to a common goal, management would be more difficult. Thank you very much for the patient hearing.
Hello, my name is Professor Andrew Davis. I'm Professor of Palliative Medicine at Trinity College Dublin, University College Dublin, and Our Lady's Hospice in Dublin. And I'm talking about difficult breakthrough cancer pain today. I'd like to thank you for the invitation to speak at this meeting. These are my disclosures. And I thought I'd start off by looking at what the Oxford English Dictionary definition of difficult is. And it's a term that we use a lot in everyday life, but this is the sort of the official term. Not easy and requiring much effort or skill. I think the theme of my talk today will be that the management of patients with difficult breakthrough pain, in fact, difficult pain or difficult any symptom, involves some very basic clinical skills, taking an appropriate history, performing a thorough examination, and if necessary, doing appropriate investigations. And if you do that, then in most cases, seemingly difficult problems will become much easier to manage. So this is a quote from a paper by Kath Weber et al. Just to highlight the impact of pain on patients' life. This is patient with breakthrough pain. So while breakthrough pain may be difficult for us to manage, in terms of its impact on quality of life of the patients, it has a huge impact on every aspect of their daily living, associated with physical morbidity, psychological morbidity. It has significant effects on social and working life, and is associated with significant costs, financial costs to both the patient, their families, and the healthcare system. So why might breakthrough pain be difficult? So I think I've used the word uncontrolled here rather than difficult. I think often there's a failure to diagnose or a misdiagnosis of the fact that the patient doesn't have breakthrough pain, they have uncontrolled background pain, and I'll discuss that a bit more in the next few slides. Inadequate assessment, inadequate, inappropriate treatment, sort of one size fits all, and again, I'll come back to that later on in the talk. And I think inadequate reassessment, inadequate follow-up with the patients to review the management strategy that's been put in place, but equally to see whether there has been some change in the underlying pain. So most of the patients I see have advanced cancer and their disease is progressing, and therefore their pain will change over time. Pain may get worse, new pains may appear, new pains may predominate. I think there's often a failure to refer if we don't or can't manage the pain or other symptoms. Then we should refer on to other people who may be able to offer a different opinion or a different treatment strategy. Another, the generic barriers to pain control that apply to all types of pain, not just breakthrough pain. And again, I'll highlight a couple of issues there. And then there is a small group of patients that do have difficult to control pain. But actually, I'm not going to talk too much about that in this talk. I'm going to focus on the other areas. So definition, what are we talking about in terms of breakthrough pain? So this is the APM, the Association of Palliative Medicine of Great Britain and Ireland's definition. And what's important about this definition, and most of the definitions in the literature, the good ones at least, is that you can't have breakthrough pain unless your background pain, your round-the-clock pain, your constant pain is well controlled. And the APM went on to develop some diagnostic criteria. These criteria have been validated. And essentially, you just need to ask three very simple questions. Does the patient have background pain? So that's pain that's there for most of the time, more than 12 hours a day. Or would they have if they weren't taking analgesia? Is that pain well controlled? And in our studies, what we've used is a verbal rating scale of none, mild, moderate, or severe. And we felt that patients with controlled background pain would say that it was mild or non-existent for most of the time. And in those circumstances, does the patient have transient exacerbations of the pain? And if the answer to that is yes, then the patient has breakthrough pain. And why is this important? Well, because patients with uncontrolled background pain and other groups of patients will have flares of pain from time to time. And the management of breakthrough pain is very different from the management of uncontrolled background pain and some of those other scenarios. So just a little bit about clinical features, and this is really important in terms of management strategy. So breakthrough pain, like neuropathic pain, like cancer pain, is a very heterogeneous condition. And there are two main subtypes: spontaneous pain, that's pain that comes on out of the blue. It's not correlated with any particular activity or event. And an instant pain where there is some sort of trigger, recognizable trigger. But even within instant pain, there's a huge variety of clinical scenarios. So these are two patients with instant pain. The patient on the left is the patient with metastatic breast cancer who has a lytic lesion in her femur. Every time she weight bears on that leg, she gets excruciating pain, but while she sits, she has no pain at all. That's instant pain. Similarly, the patient on the right is a patient who has oral mucositis following radiotherapy, chemoradiotherapy, and they, again, their pain is relatively well controlled until they try and eat or drink. Now, the management of these two patients is completely different. The natural history of these conditions is completely different, but they both have the same type of underlying pain. What's also important is that the physical characteristics of the pain vary hugely. The time to reach peak intensity varies. In most cases, it's in a relatively short period of time. And more importantly, the duration is very variable. And this is really important when you're thinking about treatment. A typical patient will have an episode of pain that comes on very quickly, within a few minutes, and lasts for up to an hour. So when thinking about some sort of pharmacological intervention, you need something that will work very quickly, but will not last for longer than the duration of the episode. So this comes back to the importance of assessment and targeted treatment for the pain and for the patient. So assessment is really important. It's not just a case of this patient has breakthrough pain, so we will give them what we give everybody else for breakthrough pain. The assessment is very straightforward. It's what we should be doing for all symptoms and all types of pain. What's the cause? what's the pathophysiology, what factors, pain-related factors and patient-related factors may indicate or contraindicate some sort of treatment in this situation. And while assessment is really important, reassessment is just as important. And that needs to be done in a timely fashion. So has the intervention worked? Is the intervention well tolerated? Are the patients taking the intervention? And as I've already said, has there been a change in pain over time? And reassessment needs to be done in a timely fashion after the intervention. You need time to allow the intervention to work, but it needs to be continued because of the nature of the underlying condition, the progressive nature of cancer and cancer pain. So management, I'm going to spend quite a bit of time talking about the management. And I've sort of alluded to this already. There is this mantra within palliative care that the management of breakthrough pain is 1/6 of the daily dose of morphine, if that's the opioid of choice. And that's the same treatment for everybody. This is what has been taught for 50 years in palliative care. And this is a picture of Charlton Heston as Moses coming down from Mount Sinai with the 10 Commandments. And this is ingrained in practice. And as I'll go on to show you, this actually makes very little sense for the majority of the patients that we see. So in terms of management, it's not just about giving as required doses of opioids. There's a whole range of things that can be done to improve breakthrough pain. And these are some of the options that are available. And it's really important to, as I say, assess the patient and understand what is going on in terms of the pain and target the treatment, if at all possible, to the underlying cause of the pain or precipitants of the pain. Now, these are some recommendations from the Association of Palliative Medicine. These were published in 2009, and a couple of years ago, there was a review of the literature to see whether there had been any, whether these needed to be updated. And essentially, these still apply, and these are the sort of recommendations that are present in many international guidelines on the management of breakthrough pain. So some of these I've already talked about: the importance of assessment, the fact that management should be individualized, and that you need to consider what the underlying cause of the pain is. So just because the patient's got cancer doesn't mean that their breakthrough pain is related to their cancer, but in most cases it will be, and therefore you need to liaise with the oncologist about other options for management, such as radiotherapy if somebody has bone metastases, initiation of bisphosphonate therapy, etc., etc. What brings on the pain in those patients with instant pain? Is there something that can be done about that? And one thing that's often, I think, forgotten about is the fact that it may be possible to modify the background, the around-the-clock analgesia, to reduce the frequency or severity of breakthrough pain episodes. And that might involve, for example, starting a neuropathic agent in patients with neuropathic pain. It may involve increasing the dose of background opioid, even though the background pain is generally well controlled. So there are lots of potential options. And I say it's dependent on an individualized assessment. Now, for most patients, they will need some treatment for the actual breakthrough pain episode. And opioids remain the rescue medication of choice. And I will come back to the specific opioids in a minute, and about the dosage. But there are a range of other things that may be useful, in particular non-pharmacological interventions. And patients often use these while they're waiting for their analgesia to work, or instead of their analgesics, because actually they are effective and generally don't cause side effects. And the sort of things that patients use are heat, cold, distraction techniques, relaxation techniques, movement, rest. It all depends on the patient and their underlying disease. And then there are things like interventional techniques. And as I said, it's always important to think about whether you can refer on to somebody else, another specialist, for a different sort of intervention. Okay, so I mentioned that opioids are the rescue medication of choice, but there are a huge range of opioids, huge range of preparations, and it's important to target the pain with the right type of opioid. And as I said before, that depends on patient characteristics, but more importantly, on the pain characteristics, and particularly the temporal characteristics of the pain. And it should be noted that, you know, many pains, many breakthrough pains are not opioid sensitive. And so there is no point persevering with opioids if they don't cause any analgesia, and particularly if they're causing adverse effects. What is really important is that the dose of opioid needs to be titrated to the maximal effect, or the effect that is acceptable for the patient. And often there's a trade-off between efficacy and tolerability. And we know that there's a poor correlation between the dose of opioid required to control background pain and the dose of opioid required to manage breakthrough pain. So this is just a graph just showing you about a typical breakthrough pain episode lasts 60 minutes, but many patients have episodes that are much shorter than that. The onset effect of oral opioids, and in this case morphine, is about 30 minutes. The peak effect is 60 minutes, and the duration of effect is 4 hours. So as you can see, for half of this episode, the patients get no analgesia from the morphine. They are starting to get full effect just as the pain is spontaneously getting better. And then for the next 3 hours, they have excess opioid, excess morphine floating around, and that's the thing that causes the adverse effects. So there are a range of different products that are available. I'm not quite sure what's available on the Indian market, but this was a study comparing the onset of action of different breakthrough medications. So the first two are intranasal fentanyl preparations. The next four are oral transmucosal fentanyl products, and the last one, the bottom one, is oral morphine. And so what you can see from this this chart is the fact that the oral transmucosal fentanyl preparations have a quicker onset of action than oral morphine, or any of the oral opioids indeed, and the intranasal fentanyl products have a quicker onset of action than the oral transmucosal products. Now, that's not to say that everybody should be given a transmucosal fentanyl product. Again, it's about targeting the right patient, the right type of pain. But these drugs can be life-changing for some patients because of their speed of onset and their overall efficacy and tolerability. I've already mentioned this about titration. I said that the sort of standard that's been employed within palliative care and has been adopted in many recommendations is that you give a fixed dose. And certainly in Europe, that has been a 1/6 of the daily dose. In the US, sometimes that's been a 1/10 of the daily dose of whatever the background opioid was. But actually, we have known for a long time that it's not just the newer transdermal fentanyl products where there is a poor correlation, in fact, no correlation between the dose of opioid needed to control the background pain and the dose of opioid needed to treat breakthrough pain episodes. But the same is true of oral opioids. This is a study from 2001, one of the first studies to look at the transmucosal fentanyl products. In this case, it was the Actiq lozenge. But as part of this study, they titrated the dose of oral morphine as well to the optimal dose to manage breakthrough pain episodes. And as you can see in the graph on the left-hand side, there are patients on relatively big doses of around-the-clock morphine who required very small doses of as required morphine to manage their breakthrough pain, and vice versa. So it's always important to titrate, and titration is a two-way step. You can titrate up, but you can also titrate down. And what we're looking for is the optimal balance between efficacy and tolerability. So I wanted to talk a little bit about barriers. So we know there are lots of barriers to pain control, and all of those barriers are equally to breakthrough pain. So there's the issue about concerns about opioids, about becoming tolerant, about becoming addicted, and I'll talk a bit more about addiction in a minute. There's the availability of products, and certainly with the newer transmucosal fentanyl products, one of the concerns has been around the cost and the relative cost versus an oral opioid. And I think, again, this comes down to the individual patient, the individual circumstance. The drugs tend to be, the cost price of the drugs tends to be higher. But if these drugs are effective, then from a health economic point of view, the fact that the patient is presenting less to their primary care physician, to secondary care facilities, is able to become more independent. It allows their family to go to work. It allows the patient to go to work. Then it is a cost worth paying. Equally importantly, prescribing a drug because it's cheap is not a good idea. And there are many patients who are prescribed oral opioids for breakthrough pain, where the opioids are doing absolutely nothing in terms of improving the pain. They are often causing adverse effects, and the money, even though it's a small amount, is a waste, and that money will add up over time. So the cost is important, but you need to think about not just the cost of the drug, but the overall cost of having uncontrolled breakthrough pain. And I just wanted to talk a little bit about abuse and addiction. And we know that worldwide there is a problem with addiction to opioids. And there has been concern in terms of breakthrough pain that these rapid onset opioids, these transmucosal fentanyl products, would increase the problem in terms of abuse and addiction. Because drug addicts try to get the drugs in as quickly as possible. That's why they inject them, that's why they inhale them, rather than try and take them orally. The thing about drug addicts is that when they continue to take opioids, they're doing that for two reasons. One is to get a high, but more importantly, to prevent withdrawal. And when you want to prevent withdrawal, what you really need is something that is long lasting. And with these transmucosal fentanyl products, they only last for about an hour. So while they may give you a high, they don't actually help in terms of preventing the withdrawal. And if you look at the data, for instance, the European Union have a database from all of the 28 countries in the European Union about adverse effects from all of the drugs that are licensed in the European Union. The reports of abuse and addiction with the transmucosal fentanyls are dwarfed by the number of cases of abuse and addiction with drugs such as oxycodone, and particularly modified release oxycodone, and the gabapentinoids, gabapentin and pregabalin. So not prescribing that group of drugs just because of the concerns about abuse and addiction is not warranted. So if you have a patient that you don't seem to be winning in terms of managing their breakthrough pain, you need to think about all of the usual barriers to pain control, as well as the specific situation regarding the breakthrough pain in that patient. So I just want to briefly finish by saying that or reiterating that breakthrough pain is a very heterogeneous condition. There's not a one-size-fits-all. a sixth of the daily dose or any ratio of an oral opioid is not appropriate for all patients, and it's in fact appropriate for very few patients. There are lots of options, and you should consider all of those options, as well as prescribing an as required opioid to manage the episodes. And I think Paracelsus summed this up really nicely, is that we need to understand what we are doing before we decide how we're going to manage the problem. And so the art of management, and I think medicine is an art as well as a science, involve adequate assessment, appropriate treatment based on the assessment, in other words, individualized treatment, and then reassessment. And that reassessment then should guide ongoing treatment. So I hope that will help if you come across some difficult cases. What I would say is there are clearly some patients who do have truly difficult to control breakthrough pain. And I would recommend in those situations that you discuss it with colleagues and or refer to somebody who has expertise in managing this type of pain. So thank you very much, and I'm happy to take questions in the upcoming session. Thank you very much.
Hello, everybody, and so pleased to be with you. Thank you very much for inviting me to contribute to managing patients with difficult pain. Big thank you to Dr. Shushma from the Indian Association of Palliative Care, Dr. Anjum from the impressive Bhagwan Mahavir Cancer Hospital. I've been there. It's a lovely place, and personally shown round by Dr. Anjum. And of course, all of you from Jaipur and across India. I have many friends amongst you, and I have always appreciated how you've looked after me and taught me a little bit about the realities of palliative care in India. So thank you for inviting me. I wish you continue with a great conference from wherever you are in India or in the world. All the very best. And of course, greetings from London. So welcome to Psychosocial Spiritual Care. I'm going to do a sort of general grand tour of patients and of psychosocial spiritual care to celebrate this occasion. And yeah, let the patients tell the story. And thank you to the patients who have given me their permission. Dr. Twycross has taught so many of us and thousands of people from around the world, including myself. And almost 30 years ago, he defined the three essential components of palliative care, and of course included psychosocial support, which has been integral from the start. You'll be familiar with this image, the iceberg, where physical symptoms are often visible, but of course not always. But certainly many of the psychological, social, spiritual, financial, and we must add all aspects of life, sexual, cultural, and so on, often underneath the surface, invisible. And it's our skill that helps the patient or family give voice to their other needs, if they want to, and at the time they want to. Palliative medicine is only part of palliative care, 50%, said Dr. Ventafrida, one of the founders of the European Association for Palliative Care. The other 50% is the holistic approach. Both make up palliative care. But I'm concerned about social death. Yes, there is physician-assisted pain when the pain isn't adequately managed or controlled. But in psychosocial spiritual pain, I'm very concerned about the experience of social death, the pain of isolation, people walking away because they don't know how to address the patient. So often still, even now, after years of public education, people can't talk about the word cancer. The pain of society's attitudes, the stigma, the pain of parting, family pain, financial pain, cultural, religious, existential pain. We need to think of the interconnectedness, the interaction, and the interdependence between all aspects of pain and of patients' lives, between the physical, psychosocial, spiritual pain and aspects. It's a sort of set of relationships that act and interact. One patient's daughter said to me on a home visit, please don't give him the morphine, it upsets me. So what have we learned over the last 30 years? Psychosocial spiritual care can be really scary, can be painful. The one thing we cannot do for patients is give them back their full health, or for bereaved families to bring their loved one back. And it can nevertheless be very satisfying. One lady I visited, this is the last day I saw her before I left that particular job, and I went to say goodbye to Judy, who was a head teacher in a local grammar school, and there she is with her husband. So she reminded me that the attention to the whole person, what's important to that person, is what we need to talk about and what we need to discover. We're talking about listening to the stories that people have in them that give shape and body to people's lives. And on my last visit, as I said goodbye, Judy said to me, you know, all the circles of life and love have come together for me. And she was kind of ready. Yeah. We need to help with people's fears, the unknown, anxieties, depression, change, bereavement, and give information, listen, and suggest. We've learned about helping families say their sorries, thank yous, and goodbye, if they want to, and in their own unique way. We need to unlock the inner world of patients and families and offer them external resources. We need to get behind the words. We need to learn from the patients, working with the healthy. People have opinions, people have had education, people may have brought up children, dealt with problems, know how to laugh. Not all of the patient is dying. We do this work in a kind of paraphernalia, a complex mix of contradictions, paradoxes, and ambiguities, shades of grey. It's not black and white. We respond to patients who want to acknowledge, at the same time they want to deny. There's hope, but there's also despair. They want to talk, but also be left alone in silence. They want to receive help, at the same time hold us away. We certainly spend times with great moments of sorrow, but also great joy to celebrate, and to be able to say to families, you kept your dad at home to look after him for so long and to end his life in familiar surroundings. That really is something to celebrate. Psychosocial spiritual care affects our feelings, our behavior, and our thinking. So why is loss, bereavement, and goodbye so painful? It's because we're attached. And we now know, thinking about the COVID crisis, the pandemic, we now know how difficult the feelings of loss and parting have been during the COVID crisis. No chance to say goodbye, no last whispers in the ear of their loved one. We know that early experiences can affect the present, and loss and change starts from the moment we're born. You'll see here the power of attachment. And a lady whose baby had died, she was just in total pain and in despair and very, very anguished. She was a sculptor or sculptress, and the only way she could express herself was making these images. Despair. And something of the mixed feelings, the need for support, but not protection. Everyone has their different way of expressing themselves and their loss and grief. The loss of a loved person is one of the most intensely painful experiences any human being can suffer. And not only is it painful to experience, but also painful to witness, if only because we are so impotent to help. But we need to also identify patients' strengths and resources. They have them. In the day center, a group were asked to record their motto, make a kind of crest with something they stand for. And one man wrote, "We are strong, no matter how ill we shall be." And that's what he wanted to say to the world. The iceberg theory of access, that we only have access to part of the patient's world, and we need to work with what we have access to. And the last part of this talk, I'd like to just finish with comments about what worries you most. Who have you got around you? How does this illness affect you? What keeps you going? You are still a person, and we'll do our best for you. I approached this man with a nurse on a home visit. It was a very late referral, and we spent a lot of time listening to him and his wife. And at the end, I crouched down by him, his side of the bed, and I said, "Just tell us what worries you most of all amongst everything we've talked about." And he turned to his wife and he said, "She'll be left with all the bills to pay." He was worried about her and how she'd manage financially. But what about society? Society with its stigma, discrimination, its taboos. We need to remember the pressure society puts on patients and families. Who have you got around you? We try and help this family come together to work as a team and communicate and help their loved one. And remember that with children, that you cannot not communicate with children. Cancer can affect the family in much the same way as it affects the body, causing deterioration if left untreated. And looking to the research, this randomized control study from Kisane and Block told us that family coping was noteworthy as the most consistent correlate of bereavement outcome. The regular use of family trees and family meetings as tools for assessment and therapeutic intervention. Frank, proud grandfather of his 13-month-old grandson, Mark. Here we have Mark, now 18 years old, caring for his terminally ill granddad. A picture of duty, commitment, family loyalty, and a reminder that we need to look after the caregiver. Most of the care is given by families and caregivers, not by us professionals. But doing this work, we see neglect, malpractice, and sometimes abuse. How does this illness affect you? And the need for economic and financial help. Being ill is costly. Financial pain is real. What keeps you going? This volunteer says as she reaches out to this lady. In getting to the spiritual aspects of care, we need to explore meaning, beliefs, existential aspects, culture, and creativity and values. So, just coming to the end, you are still a person. Making meaning is so important, and people's creativity. This patient on the left was joining in with making elephants with clay, maybe a last present for her grandchildren. And the man on the right, every time his wife appeared in the room where the nurse and I were talking to him, he held back his tears, and she kept saying, "But I always tell him to smile." And as we left the house one day, we noticed the plaque on a pebble near the door, which said, "Smile." And we had to respect that's the way this couple wanted to live the illness, with a certain amount of collusion. Illness affects the most intimate part of relationships, intimacy and the feeling of being lovable. We'll do our best for you. We need to create time and moments to connect with the person. When Dame Cicely Saunders opened my master's course, one of the bright students said to her she had founded the whole of hospice and palliative care. And a student said to her, "What do you say to people who are dying and who are bereaved?" And she just responded by saying, "But the response words are silence." And that's so important in our work, just being with people in silence. Helping people discover life while losing it is the day-to-day work of palliative care. So in conclusion, we need to create a safe place to suffer, and that's done in a good relationship. Keep questioning what we do. Words are not the only language, and sometimes we lose the gift of doing. Don't set yourself up as a superman or superwoman. We just need to be good enough to work with the patients and families. People need, after all, good communication, compassion, collaboration, teamwork, and just good care. The Chinese for listening reminds us that we listen with our ears, but also with the whole person, with our eyes, with undivided attention, and of course, listening with the ear of the heart. The good Lord gave us 2 ears and 1 tongue, and we need to remember to use them in that order. Learning to promote resilience, the therapeutic process is enriched as we practice the art of the possible. And just remember, there is an underlying optimism at the heart of palliative care. So keep what you're doing, live life, have fun, and laugh, and always remember, be children again. So thank you, everyone. And until we meet again, all the best. Goodbye.
A very good afternoon to all of you. I'm thankful to the organizers for giving me this opportunity to speak on interventions for cancer pain. I'm Dr. Mayank Gupta, Associate Professor and Head Department of Anesthesiology, AIIMS Bathinda. So this is the brief overview of my presentation, that why is it that some cancer pains are refractory to conventional medical management? What are the certain difficult to manage cancer pain conditions which are amenable to interventions? Which interventions are suitable for different cancer pain syndromes? And how to go about proper patient selection for interventional pain management. So why is it important to know about difficult to manage cancer pain? Because of the sheer magnitude of the problem. We know that about 1/3 of the patients with cancer and 2/3 of the patients with advanced cancer have pain. Although the WHO analgesic ladder has revolutionized the management of cancer pain, however, a number of systematic reviews till date have shown that about 10 to 20% of cancer pain patients fail to respond to conventional medical management. This may be because of rapid disease progression or development of tolerance to opioids, development of intolerable side effects which prevent further dose escalation of the opioids. It may be due to certain pain mechanisms, which I'll be discussing in detail in a short while, or due to pharmacodynamic or genetic changes like cytochrome P2D6 mutations in case of codeine. Or opioid escalation might not be possible in patients with multi-organ failure. In fact, a gradual increase in dose of opioids, which is not followed by increase in analgesia, should raise the suspicion that the treatment is ineffective and it's the pain is not responding to conventional medical management, because further increase in dose of opioids may lead to opioid-induced hyperalgesia. I'll be discussing three particular difficult to manage cancer pain conditions which are amenable to interventions. The first one is breakthrough pain, the incident pain, and the neuropathic pain. First, coming on to breakthrough pain. Breakthrough pain is any spike of pain which occurs against a background of well-controlled pain. They can be managed with rescue analgesics if they are infrequent, say 2 to 3 in a day. However, if the breakthrough pains are very frequent, then the usual teaching is that the background analgesia should be increased. However, increasing background analgesia for frequent breakthrough pain may result in development of side effects like drowsiness and sedation. Same is for incident pain, like in patients with pathological fracture. If the incident pain is too frequent and we keep on increasing the background opioids to cover for these spikes of pain, they may result in excessive dosage for the period in between these incidents or breakthrough pains. Third one is the neuropathic pain. We know that a subset of cancer pain patients have a component of neuropathic pain. The most common etiology is the compression of the nerve roots. However, other etiologies like due to the treatment like chemotherapy, radiotherapy, or surgery may be the causes for neuropathic cancer pain. There are a number of neuropathic syndromes which are associated with cancer pain, both due to tumor as well as due to treatment. They may involve the peripheral nervous system, central nervous system, or both the peripheral and central nervous system. So why is it that the neuropathic pain is sometimes resistant to the treatment? Because a number of cellular biochemical changes similar to what happens with opioid tolerance occur in neuropathic pain, like activation of NMDA receptors and wind-up phenomena, which makes it poorly responsive to opioids. It has been seen that 50% of patients with neuropathic pain have difficult to manage cancer pain. The requirement of opioid analgesics is greater, and these cellular biochemical changes results in change in the dose response curve too often, so that they have a higher propensity to develop opioid-induced hyperalgesia. What's more ironical is that it's difficult to detect neuropathic cancer pain with the usual questionnaires or tools we use for non-cancer neuropathic pain. For example, pain detector in SLANs have not been found to be sensitive and specific enough to detect neuropathic cancer pain with certainty. A number of treatment recommendations have been given for neuropathic non-cancer pain. However, as we know that most of the cancer patients have a mixed nociceptive neuropathic pain. So therefore, a pragmatic approach is to start anti-neuropathic medications along with the opioids for these patients. And if we suspect that the neuropathic pain is due to compression or inflammation, we may start opioids. If they are not effective, suppose after 3 days or 5 days, maybe we may stop it. However, the patient responds, then we can continue and then taper. They have to be prescribed along with proton pump inhibitors. So what to do when the conventional medical management is ineffective and the disease modifying treatments are either not indicated or they are also ineffective in managing patients' pain. Such patients continue to suffer. And as we know that if pain relief is has been declared as a fundamental human right, and it is of utmost importance to provide adequate pain relief to allow patients to die with dignity. Unrelieved pain is associated with poor quality of life, poor function, poor emotional health, and in fact, reduced survival as well. So in such cases, interventional pain management provides a useful bridge when the WHO analgesic letter is ineffective and the disease-modifying treatments are not possible. That stands for all breakthrough pain, incident pain, neuropathic pain. The particular interventions I'll be discussing in a short while, and which interventions are indicated for which sort of a pain. Not just pain, these interventions have been associated with increase in quality of life in patients with intractable pain. They maximize the pain control, improve the quality of life, and at the same time minimize the side effects and the treatment complications. As a result of all these benefits, interventions have been recommended as the 4th step of WHO analgesic ladder. In fact, National Institute of Clinical Excellence UK recommends that every comprehensive cancer center should have an anesthesiologist with experience in interventional pain management. So what are these interventional pain management? So it's a branch of medicine which uses minimally invasive procedure for diagnosis and treatment of pain. We can classify these interventions on the basis of mechanism of their action. For example, targeted delivery of drugs like local anesthetic and steroids. Example is a celiac plexus block. Neuroablation like chemical sympathectomies. Example is celiac plexus neurolysis. And neuromodulation like pulse radiofrequency and spinal cord stimulation. We can also classify them on the basis of intention. For example, a diagnostic celiac plexus block followed by a therapeutic celiac plexus neurolysis. The nervous system they are targeting, is it somatic, for example, brachial plexus or trigeminal nerve, or sympathetic like celiac plexus or sphenopalatine ganglion? So a number of interventions can be performed for various regional cancer pain syndromes. I'll be discussing them one by one. So for intractable head and neck cancer pain, if it is somatic in nature, for example, any Poitier fossa tumor or CT angle tumor leading to compression of trigeminal nerve and causing pain within the distribution of trigeminal nerve, is then trigeminal radiofrequency ablation can be performed. In fact, tumors are responsible for a significant number of secondary trigeminal neuralgia. A retrospective analysis at Mayo Clinic found that tumors were responsible for approximately 300 cases of secondary trigeminal neuralgia, and there was a time lag between the presentation and the detection of tumor as the cause of secondary trigeminal neuralgia. If one particular division of trigeminal nerve is involved, then we can perform a maxillary or a mandibular nerve block or radiofrequency ablation. If the pain is further localized, we can go for a supraorbital, infraorbital, or a mental nerve blocks. If the pain, head and neck cancer pain is sympathetic in origin, we can go for a sphenopalatine ganglion block. We can go for a diagnostic block, which is a transnasal, and followed by therapeutic block. This is sphenopalatine ganglion is largest group of ganglion outside the cranium. It hangs through the maxillary nerve in the pterygopalatine fossa, and all the efferents from the face, they travel via the sphenopalatine ganglion and then to the trigeminal ganglia. If the diagnostic block works, then we can perform a therapeutic block like pulse radiofrequency or radiofrequency ablation through the transcoronoid approach. We can also teach diagnostic block to the patient and the caregiver so that they can perform this block at home. For patients with CA tongue or CA oropharynx having frequent breakthrough pains or odynophagia, we can do a pulse radiofrequency of glossopharyngeal nerve. So this is an example of fluoroscopic guided glossopharyngeal nerve block. With the help of a needle, you hit the stellate process and then slip it off posteriorly. The thing to note is try to avoid local anesthetic at this site because the vagus nerve travels alongside the glossopharyngeal nerve. They have been found effective in managing odynophagia and reducing the severity of side effects like nausea. If the pain is in the distribution of the greater and lesser occipital nerve, for example, in patients with occipital condyle syndrome, you can perform greater occipital and lesser occipital nerve block followed by ablations. So what sort of interventions can be performed in patients with intractable thoracic and chest wall pain? If the pain is due to metastasis, these patients have frequent breakthrough pains associated with coughing or breathing. We can perform fluoroscopic, like in the right-sided fluoroscopic picture. We can perform an intercostal nerve block followed by intercostal nerve neurolysis or radiofrequency ablation. Paravertebral blocks or thoracic epidural blocks, which the anesthesiologists are more familiar with, can be performed for somatic pain in the thoracic distribution. If the pain is in the distribution of a particular dermatome, we can perform pulsed RF of thoracic DRG. However, this is not a very common procedure. If the patient has back pain due to vertebral compression, fracture due to spinal metastasis, we can either perform a vertebroplasty in which a cement is injected in the fractured vertebra, or kyphoplasty in which a balloon is first inflated to create a cavity followed by injection of the PMMA cement. A number of systematic reviews have shown that balloon kyphoplasty is more effective than vertebroplasty in patients with pain due to vertebral compression fractures. In fact, the ASPN, that is American Society of Pain and Neuroscience 2020 guidelines, they give level 1 recommendation for vertebral augmentation. For intractable cancer pain in the abdominal and pelvic cancer, the highest level of evidence is for celiac plexus block and neurolysis for upper abdominal cancer pain. This was a Cochrane review which was done in 2011. At that time, they found although the difference in the pain score as compared to conventional medical management was not much, but the fewer adverse effects in patients who underwent celiac plexus block compared to opioids was considered important by the patients. The 2015 guidelines gave a level of recommendation of 2A+, that is the highest level of evidence for celiac plexus block. In patients in whom there is involvement of the celiac plexus by the tumor, we can perform a splanchnic nerve block. The level of evidence is 2B+. Celiac plexus block can be performed blind, but most commonly it is performed image guided with the help of fluoroscopy, ultrasound, or CT scan. The 2020 ISSP guidelines gave level 1 evidence for celiac plexus neurolysis, same as for ASPN guidelines. Most of the complications are transient. For example, transient diarrhea. Patient may develop hypertension due to sympathectomy, so it is very important to optimize the fluid status prior to performing the block. However, there may be serious complications like paraplegia because of injection into the artery of Eden-Kuyvix. Therefore, it is very important to know the anatomy, the sonoanatomy or the fluoroanatomy, and have a proper training before contemplating these blocks. Not just pain, they have been found to they lead to improvement in mood as well as survival in patients with unresectable pancreatic cancer. For patients with lower abdominal pain due to pelvic malignancy, superior hypogastric plexus block and neurolysis have a 2B+ recommendation. For patients with CA, rectum, anus, and vagina and pain in the perineal region, you can perform ganglion impaired block and neurolysis. Similarly, patients who have a sympathetically mediated abdominal or pelvic or lower limb pain, we can perform lumbar sympathetic block and neurolysis. So now coming on to intrathecal analgesia and intrathecal drug delivery system, it provides a highly selective pain relief, a significant reduction in the dosage of opioids, hence reduction in side effects, and a pump can be implanted subcutaneously, which keeps on delivering medication for a prolonged period of time. The indications are same for as any intervention, that is pain which is not responsive to opioids or intolerable side effects, or pain which is not amenable to any other interventional techniques like neurolytic blocks. It is usually performed when the pain is localized and in a well-defined area. Although a number of drugs have been given through intrathecal drug delivery route, but morphine and ziconotide are the only two medications which have FDA approval. It leads to significant reduction in the dose of morphine to the tune of 300. However, the cost is high. That is why it is suitable for patients with a life expectancy of more than 2 to 3 months. If the expected duration of use is more than 3 weeks, then the intrathecal catheters are much safer than the epidural catheter. The dose requirement is much less with the intrathecal route compared with the epidural route. So these pictures show the fluoroscopic guided IDDS implantation with implantation of the pump within the subcutaneous tissues. The location of the catheter tip depends upon the location of the pain. A number of prospective cohort studies have shown intrathecal drug delivery system to be effective in managing pain up to 12 months and improving quality of life in patients with intractable pain. However, the level of evidence is only moderate. Most of these studies are either cohort studies or case series or poorly conducted randomized controlled trials. The only randomized trial published till date comparing intrathecal drug delivery system with conventional medical management showed that the IDDS was effective in relieving pain both at 4 weeks and 12 weeks and reducing the opioid-related side effects. What's more important to know is that there was an improvement in the survival in patients who received IDDS compared to conventional medical management. As with any intervention, they are also prone for complications, which may be catheter-related, pump-related, procedure-related, or drug-related. The latest ASPN guidelines give them a level of 1 evidence for patients with intractable pain, which is not responding to any other procedure. Sacral neurolysis can be done for cancer pain in the perineal pain. Spinal cord stimulation is spinal cord stimulation can be tried for chronic neuropathic cancer pain, which is not responding to other interventions or conventional medical management. It works on the gate control theory of pain. The pump generator is implanted subcutaneously. This is a Cochrane review which showed that spinal cord stimulator was effective in reducing pain scores at 1, 3, and 12 months in patients in whom the pain was not amenable to a conventional management. The level of evidence is 2. Peripheral nerve stimulation is like spinal cord stimulation if the pain is in the distribution of a particular nerve. Last but not the least, IV lignocaine and ketamine infusions can be tried for cancer pain which is not responding to any other intervention. Destructive procedures which were done commonly in the past, their use is becoming less and less common with the advent of WHO analgesic ladder, with the advent of other blocks like celiac plexus neurolysis. So this is how we approach a patient with difficult pain. We try to find out that what is the cause of this difficult to treat cancer pain. If it is a patient has neuropathic pain, then we start anti-neuropathic medications. If it is not responding, we can try IV ketamine infusion or switching of opioids like to methadone. If the patient is still not responding, we can try intrathecal analgesia. If the pain is in the distribution of a particular nerve, we can try nerve blocks. If it is an abdominal pain or a pelvic pain, we can try celiac plexus or superior hypogastric plexus block. If the pain does not respond to them, we can go for an intrathecal analgesia. The traditional teaching till now was that we go for interventions at the 4th step. That is when the other conventional management is either not effective or lead to adverse effects. This is termed as salvage therapy. But what about the patients who have a significant difference between the background pain and the pain on movement, for example, pathological fracture? We have already seen that increasing the dose of opioids for these patients may lead to development of side effects. Or if the pain is very localized or in the distribution of a particular dermatome and hence amenable for interventions. Or patients who present in the advanced stage, like in developing countries, and there is limited time available for opioid titration. So a lot of evidence is emerging that the salvage or the traditional therapy leads to underutilization of a useful analgesic modality. And usually the patients are being referred when they already develop metastatic disease, they have multiple sites of pain or develop psychosocial issues. When they have poor performance status, coagulopathies, which makes the intervention either not effective or makes the pain inamenable to interventions. A lot of studies have seen that what are the predictors of success of blocks like neurolytic celiac plexus block. a better performance status, lower tumor marker level, shorter pain duration, and lower opioid dose, which are seen usually in the early stage of the disease, have been found to be have better response to interventions. So the emerging evidence suggests that salvage therapy may not always be the best option, and early interventions, particularly like celiac plexus neurolysis for CA pancreas, may be effective in not only reducing pain but improving quality of life as well as survival. They lead to immediate pain control, thus avoiding the time lag which is associated with opioid titration, reduces the opioid related side effects, and improve survival like with celiac plexus neurolysis and intrathecal drug delivery system. As far as the opioid related side effects are concerned, they not only help in reducing the short-term side effects like constipation, nausea, but also long-term side effects associated with opioid use like endocrinopathies or even tumor metastasis. So this is was a randomized trial which was published in Journal of Pain and Symptom Management in 2014. In patients with 109 patients with inoperable abdominal or pelvic cancers, patients were divided into two groups. Group 1 was the early intervention group after step 1, whereas the group 2 was the traditional or the salvage therapy group, in which the interventions are applied if the step 3 opioids were ineffective. So the researchers found that the early intervention group had a better control of pain, improvement in quality of life, improved symptom scales, improved physical functioning, social functioning, cognitive functioning, and reduced consumption of opioids as well as reduced opioid related side effects. Similar benefits have been seen with early sympathetic lumbar sympathetic plexus block for management of abdominal and pelvic cancer pains. A lot of not only from abroad, a lot of emerging evidence from India shows that early interventions are effective in management of cancer pain. These interventions, they provide longer duration of pain relief, are cost effective when seen in long term. They avoid repeated visits to the hospital, which is more and more important during this COVID pandemic period. They avoid the prolonged hospital stay associated with IV titration or oral titration of opioids in patients presenting with severe cancer pain. Patients can remain at home in their usual surroundings, surrounded by their near and dear ones, and even at places where there is scarcity of medical sources like in rural areas. So I would like to conclude by saying that 10 to 20% of patients in cancer pain is amenable to conventional management, which has a significant impact on the quality of life. The usual causes are the breakthrough pain, incident pain, and the neuropathic pain. Intervention can prove to be a useful analgesic modality and can bridge the gap when the conventional medical management is ineffective and the disease modifying treatment is either not effective or not indicated. The interventions with the highest level of evidence are celiac plexus, flanking nerve, superior hypogastric plexus block, or intrathecal drug delivery system. Traditional or the salvage model is not always the best approach. In fact, the emerging evidence is in favor for early interventions for blocks like celiac plexus block for CA pancreas pain. They lead to better control of pain, quality of life, and even survival. What's more important is to select the right intervention for the right patient at the right time. And nothing can replace proper training in these interventions. So with this, thank you for listening, and I conclude my lecture. I would be more than happy to answer any questions. Thank you so much.
Excellent session on managing difficult pain, and all the lectures dwell upon all the aspects in detail. Our Dr. Babita Ghai delved into all refractory neuropathic pain conditions as well as the management issues. Then two international speakers were superb, Dr. Andrews and Dr. David Olivier. Fantastic lectures by them, recorded lectures. And Dr. Mayank Gupta also was very detailed lecture and quite a good deliberation. I admire all the four speakers. Now, any questions from anybody, because there is no question in the chat box. So any of the speaker to anybody is most welcome. You can put your questions into chat box. Dr. Sushma Bhatnagar wants to say something.
Thank you very much. I'm jumping from one session to another session. That's all I'm doing since morning because
Yeah.
everywhere it is going on so well.
Nice to see you, madam. So refreshed.
I
Even
enjoyed.
even then, yeah.
Good to see you, ma'am.
Yeah.
Thank you.
So
Yes, go
I, yeah, so I will close this session because there are no questions. All the speakers, thank you very much. And organizer, thank you very much for this opportunity. Thank you so
Pleasure.
much.
Thank you very much, sir.
Bye-bye.
Thank you,
Prableen
organizer.
wanted to say something. Hi, Babita.
Hello, ma'am.
Hi.
Ma'am, thank you very much. It has been a lovely, wonderful conference. I have been here right from the first session, 8 a.m. That was so wonderful session in Hall B, question-based session, amazing session. And I must say, congratulate the whole team for wonderful academic feast and being on time, right on time.
Like, this is all the Anjum and her team. Prableen is here. Dr. Pushpalata is there. I think they have done a lot.
Whole team.
Yes. Thank you
Thank
very
you so
much,
much. Thank
Dr.
you.
Jain, Dr. Babita, Prableen, Naveen. I think Naveen was there. Mayank is here.
Yes.
Thank you, everyone. Thank you very
Thank you
much.
very much. Thank you.
Okay, now there is a validatory function. You asked me to come to Hall A, so I'm here.
Okay.
Okay, so now we are
Thank you.
coming to the end.
Thank you very
Thank
much.
you.
Thank
Thank
you.
Bye-bye.